but there are a lot of things that we need to digest. So I need to make sure everyone understands what I will be talking about, okay? Because we will be touching on pathophysiology before we touch on treatment. So I need everyone to understand the mechanisms of action and the receptors, mechanisms that we will be tackling before we go to treatment, okay? Does anyone understand? Si practice tayo. Sige nga, can you respond?
Yes po, Doc.
Okay. So I need everyone, please turn on your audio, please. Okay? Pag hindi nag-turn on, sila yung matatawag mamaya. So may recitation tayo. Okay?
Naku.
Okay, please message also the incoming participants for our simple house rules. Okay. You may interrupt me anytime. You can raise your hands in the chat box if you have any clarifications. Okay. All right. So I am Dr. Biswanath Espaldon. I am a cardiologist from the section of cardiology, an assistant professor of the Department of Medicine, and I will be discussing primary and secondary hypertension. Our source for this lecture will be Harrison's, okay? I shall incorporate, though, some slides from the recent guidelines, just a short slide just to show us the updated classification on hypertension, and some slides from physiology, which were not discussed in the chapter of hypertension in Harrison's. Okay? So our objectives for this lecture, wait. Okay. Number one, to understand the mechanisms regulating blood pressure and how the current antihypertensive drugs exert their effects on these mechanisms. Number two, we shall differentiate between primary and secondary hypertension in terms of recognition, etiology, diagnostics, and management. And we shall review the pharmacologic and non-pharmacologic management for primary and secondary hypertension. So as a background, we know that hypertension is one of the leading causes of global burden of disease. Okay, so this is worldwide, no? Hypertension doubles the risk of cardiovascular disease, coronary heart disease, congestive heart failure, ischemic and hemorrhagic stroke, renal failure, and peripheral arterial disease. So epidemiologically, blood pressure levels vary with age, okay? As the rate of age increases, BP also increases, and the prevalence of hypertension also varies among countries, no? And among subpopulations within a country. It also varies within or across races. So you have a different prevalence, for example, in the Black population versus the white population versus the Asian population. But in general, average systolic blood pressure is higher for women during the early adulthood, okay? But when the female population reaches their menopausal age, more than 60 years old, their systolic blood pressure turns to be higher compared to men, okay? So very important that you remember that, especially our female students here, okay? That when you reach menopause, you tend to have higher blood pressure compared to your male counterparts, okay? And that the reason for that is because you lose the protection of your hormones. Okay? So among adults, the diastolic blood pressure, as we've said earlier, also increases progressively, not only the systolic, but also the diastolic, until around 50 years, wherein the systolic blood pressure turns to decrease already, okay, resulting in a widened pulse pressure. So it's not unusual that we see uh, a senior citizen or the elderly having blood pressures of, say, 150 over 50 or 140 over 50. Okay, they tend to have lower diastolic blood pressure because of this widening of the pulse pressure, because of the stiffening of their arteries, the relaxation abnormality of their left ventricle suffers, no, in the elderly population. Okay, clear so far? Okay, so we have pointed out already some important points there. Okay, some important information. I hope you pick those up, huh? So this is a live recording, huh? So this is not, sorry, this is a live lecture, not a recorded lecture. Okay, so there will be a lot of things that will not be present in the slides that I will be presenting. I tend to want to talk more than show you things in the PowerPoint slide. So that's why I need you to participate and listen. Okay. So pathophysiology. Okay. So when we talk about hypertension, okay, we talk about arterial blood pressure elevation. Okay. So we will not talk about pulmonary hypertension or venous hypertension. Okay. So that will be covered in the other lectures in the cardiology section. Okay. But when we say hypertension, strictly, we say it's the elevation of your arterial blood pressure. So artery, arterial blood pressure, such that this arterial blood pressure is influenced by mainly, by two important factors here: cardiac output and your peripheral arterial resistance. Okay, try to digest this already. Okay, I will slowly uh, incorporate terms, okay, which we will then use eventually in our lecture, no? So hindi na natin to babalikan, ha? There are important words and terms here that we shall be using again and again in our lecture. Okay, so arterial blood pressure, factor of cardiac output, and peripheral arterial resistance. So cardiac output, as we know from physiology, there's a formula for that, right? So stroke volume times your heart rate is your cardiac output. Okay, so meaning in this slide alone, you can already point out factors that may increase blood pressure. Okay? Okay, so let's test, no, your attentiveness. So I will call Paulo Fabros. Okay, Paulo. Okay, very good. So meaning with this concept, no, we're just here like around 5 minutes, but we have already discussed important concept. So meaning, give me a factor that can increase blood pressure in this slide. So kapag, if the heart rate is, okay, so with this slide, you can see here, no, if you increase your heart rate, or if a patient has increased heart rate, of course, it will increase your cardiac output. That will tend to increase your blood pressure. Okay. Likewise, if you increase your stroke volume, you increase your cardiac output, then you increase your blood pressure. Okay. So we go now to peripheral arterial resistance. So resistance is, I would say, it's a self-explanatory term for hypertension because of the word resistance, no? Okay. When we say resistance in common parlance, it's there is difficulty. Okay, resistance. Okay, there is resistance. there is difficulty in whatever, no? In blood flow, difficulty, there's constriction. Okay. So this is self-explanatory, no? Very obvious. So if you increase your peripheral arterial resistance, you increase your blood pressure. So what are the factors that affect resistance? Of course, your vascular structure. Again, we're talking about artery, huh? Artery, not veins. So in an artery, you know that there are layers in our artery. So the vascular structure itself can influence your arterial resistance. And of course, the vascular function. We will learn later, or I hope you've already learned that before from physiology, that our endothelium is very rich in hormones. No, they exude and exert a lot of hormones to influence the function of a vessel, which is to vasodilate or vasoconstrict. So that's the vascular function. Okay, clear so far? Okay, so dito pa lang, one slide, ang dami na natin we need to digest. So you need to understand this concept, no? This simple, no? It may seem, but a lot of ideas already as we discuss and as we go through our discussion. Okay? Okay, try to understand because this is the basis for everything. Okay? Everything for your pathophysiology and for your treatment. No? The medications that we will be introducing later on shall be influencing all of these. Okay? But we will discuss all of this in detail. Okay? Okay, so starting with, again, the concept of arterial pressure. We will highlight again, when you say hypertension, we talk about artery, increase in arterial pressure. So you will learn later on, okay, that hypertension is a very complex disease because it is controlled and influenced by your kidney, the volume of the body, and your endocrine system. Okay, so renal, volume, and endocrine are exerting pressure and control over our blood pressure system. Okay, in which the blood and the total peripheral resistance are manipulated to adjust arterial. So this one, we've learned this a while ago, that cardiac output is influenced by stroke volume, where stroke volume is related to your contraction and the size of the intravascular compartment. And of course, vascular resistance determined by functional and anatomic changes in the small arteries and arterioles. So there are still a wide variety of systems, no, that we will discuss to keep cardiac output and peripheral resistance in balance. Okay, so we shall now go to the hormonal systems. In fact, the complete term should be neurohormonal systems affecting peripheral resistance. So they influence peripheral resistance by, one, stimulating vascular constriction or vasodilation. Okay. So what is responsible for vascular constriction? It's your sympathetic system and the renin, angiotensin, aldosterone system. So we will mention this again and again later on, the RAAS, okay, or the renin, angiotensin, aldosterone system. Okay, so that is responsible for vascular constriction. For vasodilation, your bradykinin is responsible for that. Okay, and number two system or factor that can influence peripheral resistance is by modulating hormones that result in excretion or retention of sodium. Okay, so your natriuretic peptides excrete sodium, and your aldosterone retains sodium. Okay, another very important slide, that we need to pick up and understand this early, okay? Because if you do not understand this, you will not understand the mechanism of actions of your medications, okay? That's why in the end, you should be very knowledgeable about hypertension already, because this alone, understanding the pathophysiology, can help you understand how the medicines work. Because lahat, no, every medicines available in the market exert their influence on this system. Okay? All right. There is also this concept of autoregulation, no? And this is a property of your vascular endothelium. So we already mentioned, no, that the vascular endothelium is very rich, no, in cells and hormones that serve as a direct contact with your circulating blood and regulates exchanges between bloodstream and surrounding tissues. No? Auto-regulate, okay, meaning it fixes defects, no, in the bloodstream. That's such that when, for example, when peripheral arterial resistance is increased, the autoregulatory systems work, no, to increase vascular resistance to maintain constant blood flow. So it corrects the defect or the error to maintain constant blood flow or function. Okay. So this is important because initially, early hypertension, early in hypertension, the initial elevation is due to increased cardiac output and expanded intravascular volume. So when peripheral resistance increases and cardiac output reverts toward normal over time. So it adapts and it autocorrects, no? So it's the function of your endothelium. So as arterial pressure increases in response to a high intake of sodium, urinary sodium excretion increases and sodium balance is maintained at the expense of an increase in arterial pressure. So while autoregulation is good, okay, it sounds good, right? Because it corrects errors, okay? But in the long run, since it's just like a cycle, in the long run, this autoregulatory mechanism eventually fails to balance, okay? So eventually, these are also the ones responsible for your increase in blood pressure, okay? So again, we've said, no, that the drugs for hypertension commonly available target these various PP control mechanisms and autoregulatory functions. Okay, to illustrate, no, to illustrate, uh, I hope you're still following, okay? So to illustrate, so sodium is a determinant of volume, okay? All right. So we've learned that from second year, no? Meaning if you have a lot of sodium, you have a lot of water, right? So it attracts water. You can see if if you guys cook, no, or use salt all the time in the kitchen, you will see that it draws fluid, okay? Sodium. It's basically the same as the sodium we have inside the body. So an increase in sodium chloride intake will increase vascular volume, which will then increase cardiac output and then will increase your blood pressure. Okay. So the autonomic nervous system, we will now go to the specific autonomic nervous system discussion. Can be classified as your arterial baroreflexes and your adrenergic reflexes. Okay, so arterial baroreflex, these are pressure sensors in your arteries. They are responsible for short-term regulation of blood pressure. This is also part of the autoregulatory mechanism. So it is mediated by your stretch-sensitive sensor or baroreceptors in your carotid sinuses and aortic arch. No? So an increased stretch of blood vessel due to increase in pressure results in an increase in the firing of signals of baroreceptors to the central nervous system, which will then influence sympathetic outflow to decrease, causing vasodilation and decreased heart rate and cardiac contractility. So short term, no? So it cannot cope eventually with an error in blood pressure if the condition or the hypertension is already long-standing. Okay? So initially it's effective, but in the long run, it becomes ineffective. Your adrenergic nervous system, on the other hand, regulates on a more long-term basis. So these are your endogenous catecholamines, your epinephrine and dopamine acting on your adrenergic receptors, no? Your alpha and beta. Okay. We shall review that in the next slide. No? So it has an important role in tonic and phasic cardiovascular regulation. Okay, so I hope you still remember this, no? Your receptors, your alpha and beta. So for alpha, you have alpha 1, alpha 2, and beta, you have beta 1 and beta 2. Okay, alpha 1 are located in your smooth muscles, okay, of your body, uh, responsible for vasoconstriction, okay, your alpha 1 receptors. It can also be found in the kidneys, no? So the alpha 1 receptors increase in renal tubular absorption of sodium. Your alpha 2, on the other hand, act as negative feedback controllers, inhibiting further norepinephrine release from your presynaptic membranes of your postganglionic nerve terminal that synthesize norepinephrine. Okay, so alpha 1, alpha 2. And then you have your beta receptors, beta 1 and beta 2. Beta 1 is found mainly in your heart and your kidney. Okay? So your beta 1 receptors in the heart is responsible for the increased rate in contractility. Okay, such that there is a medicine which we call Kent Acuna. Ano ka? Hindi ka audio on. Acuna?
Hey, Doc.
Yes, so beta 1 receptor, no? It increases rate in contractility such that there is a medicine that counters that. We call it, what do you call that medicine? A group of medicine.
Beta blockers.
Beta blockers, okay?
If
So
it's
there's an
beta,
example, no, ng, we were discussing earlier, no, that the medicines that we will learn later on exert their influence on all of these mechanisms. So your beta blocker counters this increased rate and contractility in the heart. You also have beta 1 in your kidney, which is responsible for your renin release. Okay. And your beta 2, which is found in your vascular smooth muscle, which produces vasodilation. So your beta 2 agonists are the one responsible for or active in asthma. Okay. So that's why the inhalers are your beta 2 antagonists, no? To beta 2 agonists to vasodilate, no? Your airways. Okay. So beta 2 agonists are used for the treatment of COPD, airway diseases, like asthma. Okay. So next is your renin-angiotensin aldosterone system, RAAS. Okay, RAAS is composed of three systems. No, your renin system, your angiotensin, and aldosterone. Okay, we will explain that in a while. Okay, but we will just introduce to you another term, angiotensin 2. This has vasoconstrictor properties, and it's a factor for the secretion of aldosterone. And it is a very important role in the pathogenesis of atherosclerosis. Aldosterone, on the other hand, is that hormone that is synthesized and secreted by angiotensin 2. It's a potent mineralocorticoid which retains sodium. So if you have increased aldosterone secretion, you have increased in sodium retention. Okay. In itself, it causes fibrosis, endothelial dysfunction, inflammation, and oxidative stress on the cardiovascular system. Okay, okay, so before we go on, based on what we've shown you, no, this first few slides, 7 slides, can anybody tell me another mechanism, no, for increase in hypertension or increase in blood pressure? Si Maria San Juan.
Doc, one possible way with which hypertension could result is if there is increased vasculature pressure po.
Resistance, yes. We've mentioned that earlier already. Okay. And another factor. Another factor. Kyle Santos.
Yes po, Doc.
So ano pa? Ito maisip mo. Factors that can increase hypertension.
I was gonna say the same thing po kasi, so um, I'm not sure po, Doc.
Not sure. We will not continue, ha? If you do not understand. Ang dami na nito and you will be confused later on when we talk about medication. So what other factors, aside from the ones mentioned a while ago, no, that can increase your blood pressure? So we've already mentioned, somebody mentioned about heart rate a while ago. And somebody mentioned about resistance. So what else?
Can fluid retention?
Yes, go ahead. Juan
Could
Miguel,
fluid-
Mama Mateo.
Adjusting of position po.
Sorry,
Adjusting of position
position.
from, for example, from standing to sitting or sitting to standing.
We did not talk about that in the slides that we've shown. Yeah, Paulo Fabros. Okay, sodium retention. Okay. Another one, sodium retention. So if you have a lot of sodium, you have increase in blood pressure. Okay. Meron pa ba nag-erase ng hand? Sorry, I cannot see the ones in the. So can you just if somebody is raising his or her hand, can you just speak up? Wala. Sige. Si Russell Sabado.
Doc, alpha-1 receptor stimulation po.
Okay. Stimulation of the alpha-1. Although it's now considered just a minor receptor for the development of increased blood pressure. And you will learn later on that we seldom use alpha blockers already. Kasi amongst all the receptors that we've shown earlier, okay, the least least influential of all these receptors for the development of increased blood pressure is your alpha or your alpha 1 and your alpha 2. Yeah, but if you've been following this lecture, if you look at this slide, it is also one of those factors that can increase hypertension or blood pressure. Okay, so what else? So this one, no, norepinephrine, epinephrine. If you have increased of these hormones, then you increase your tone of your blood vessel, you increase blood pressure. Okay, increase stretch of your carotid, you increase blood pressure. Okay, increase in volume. Okay, very important concept. You increase blood pressure. You increase cardiac output, you increase blood pressure. Okay, naintindihan? Yes?
Yes po, Doc.
Okay. Just turn on your audio kung ayaw niyo matawag. Okay, so we shall continue. Okay, so this is the illustration on your left is the famous very familiar RAA system or RAS, okay? So your angiotensinogen is actually produced by your liver. For it to be converted, okay, because angiotensinogen is inactive, for it to be converted to angiotensin 1, it has to be converted by renin in your kidney. So renin is found in your kidneys, no? So doon nagsa-start yung RAAS sa kidney, renin. Okay, so without renin, angiotensinogen will not be converted to angiotensin 1. Okay, that's why there are medications which we call renin inhibitors, okay, which prevents the conversion of this enzyme. Okay, ngayon kung may makakalusot pa rin, yung angiotensin 1, it again gets converted to angiotensin 2, which is a more potent property than angiotensin 1. Okay, and this the enzyme responsible for the conversion of angiotensin 1 to 2 is your angiotensin converting enzyme, your ACE, no, which are found in your lungs. Okay, so that's why we have medications called Camille Antonio. What do you call that medicine for hypertension? Camille? Is Camille Antonio away? Si Mark Navarro. Mark Navarro.
ARBs po ba daw?
Nasa ACE angiotensin converting
Ay,
enzyme.
ACE inhibitors po.
Okay. Okay, so see, madali lang, di ba, ang hypertension. If you understand the basic pathology. So that's why there are medications that inhibit your ACE, no? Your ACE inhibitors to inhibit the conversion or prevent the conversion of angiotensin 1 to angiotensin 2. Why is angiotensin 2 very important? No? Dapat hindi ma-convert siya because it is very, very potent. Okay, angiotensin 2 is very, very potent. Listed down are the actions of angiotensin 2. No? It activates your sympathetic system. It increases reabsorption of sodium and chloride. It stimulates your aldosterone secretion. It induces arteriolar vasoconstriction. It increases your antidiuretic hormone secretion, leading to increased reabsorption of water. So if you have a lot of water, you have a lot of volume, you increase your blood pressure. See, parang all-in-one na ang angiotensin 2. So this is a very, very potent hormone that needs, no, to be suppressed. And ACE inhibitors are responsible for that. Okay? So angiotensin 1 is still divided into two types, no? Your angiotensin type 1 receptor and your angiotensin type 2 receptor. Your type 1 is responsible for your aldosterone secretion. It is the one responsible for stimulating your smooth muscle cell to produce vasoconstriction and myocyte growth. Your AT2 or your angiotensin 2 receptor is responsible for sodium excretion, vasodilation, inhibits cell growth and matrix formation, and increases your sodium reabsorption. Okay, so another very important slide. Okay. Okay, we will touch on that. We will now leave the pathophysiology and the receptors, but before we leave the topic, we shall be touching on some of the medications available, okay? So that you can already correlate, no? So that's why so that we can already achieve our first objective, okay? So calcium channel blockers, okay, your CCBs, they block the entry of calcium so that it induces arterial vasodilation. your RAS inhibitors, which include your ACE inhibitors and the ARBs. The ARBs were already mentioned a while ago. Okay, your angiotensin receptor blocker and renin inhibitor. They block the vasoconstricting effects of angiotensin 2 and your sodium retaining effect of aldosterone. Beta blockers, we've mentioned this already a while ago. It blocks the action of your sympathetic system. Neurotransmitters that stimulate vasoconstriction and heart rate. Your diuretics, no? The thiazide and thiazide-like diuretic, which enhances your sodium excretion in your distal convoluted tubule. And your MRAs, no? Your mineralocorticoid receptor antagonists or aldosterone antagonists that prevents the action of aldosterone in the distal tubule and your distal convoluted tubule. Okay? Understand so far? So, yeah. So if you understand the first few, the half of the lecture, then you understand hypertension. Okay? Because our next slide will now be dwelling on the current nomenclature and the management of hypertension. Okay? So we shall now be learning when to call hypertension a hypertension and what are the terms that we need to memorize. Okay. So by definition, we usually use the current guidelines, no? Of course, you know that your textbooks are 5 years behind the current guidelines. So we need to show you this slide. Okay, this is from the Joint National Commission 8 Hypertension Guidelines and the American Heart Association 2025 guidelines to show you the recent update and what is the current classification or cutoff for normal and abnormal blood pressure. Okay, so JNC8 is actually still current. Okay, it has not yet been updated, though the last update I think was 5 years ago. You will notice here that the level of hypertension begins at 140. Okay, refer please to stage 1 hypertension column. Okay, but if you take a look at the latest, the 2025 American Heart Association, the level of hypertension has now been lowered to 130 over 80. Okay? Okay, clear? Okay, so we shall be using the current classification of hypertension, which is 130 over 80 and above. Okay, this is also included in your Harrison's textbook, okay, 22nd edition. Okay, so a normal blood pressure should be less than 120 over 80 and 120 systolic and diastolic of less than 80. Take note of the conjunction, and then or. So an elevated blood pressure is 120 to 129 or less than 80. Okay. For hypertension, stage 1. Okay, so we have 2 stages, stage 1 and stage 2. There hasn't been a stage 3, so only stage 1 and stage 2. So stage 1, your systolic blood pressure should be 130 to 139 or 80 to 89. Okay? Okay, hope you're following pa. Diane Lim, are you here with us?
Yes po, Doc.
Okay, so if you have a patient with a blood pressure of 120 over 85, how do you classify that patient?
It is elevated na po, Doc.
No, classification. 120 over 85. Anyone?
Doc, stage
Yes.
1 hypertension.
Okay, very good. The answer is there in the table, Dayan. Okay, so that's why be careful. Take note of the conjunction or siya, or. Meaning, even if the systolic is 120, okay, or kasi, or, no? Even if your systolic is normal, but you have a high diastolic pressure. In our example, the diastolic that I gave was 85, okay? Nandun na siya sa stage 1. Okay? Understand? Diyan?
Yes po, Doc.
Okay, so stage 1 hypertension na siya. Right? Okay. Si, Sarah Pico. Are you with us? Sarah Pico. Ayaw na mag-participate. O si ano na lang. Bertilio, yes, person.
Good afternoon, Doc.
Okay, so your patient came to you, the blood pressure is 129/75. How do you classify your patient?
Elevated po, Doc.
Okay, elevated blood pressure. Okay, so there are only a few things in hypertension that we need to memorize, no? And one of those is the levels of blood pressure. We don't have any choice. We really need to memorize this. Okay, understand? There's no other way to teach you the levels but to really memorize the levels. Anyway, simple lang naman, madali lang, few numbers lang. Okay. All right, we shall continue. Okay. You shall also be encountering these terms, no? When we say office BP, office meaning doctor's office yon, okay? Or clinic, okay? You have to be familiar with that term because in publications, in your textbooks, you will always be encountering the term office because abroad, in other countries, especially in the US, they really use the term office to denote clinic. Sa atin, clinic tayo lagi, no? Sa kanila office. So when you say office, that's clinic, no? So office clinic BP measurement is, of course, the most common way where patients may be able to find out their blood pressure, okay? Because most of the time, that's the only time patients find out they're hypertensive when they consult a doctor. Okay, but office BP measurement only provides a limited and potentially biased depiction of an individual's level of BP. Okay. So guidelines usually recommend complementing office BP readings with out of office BP measurement, meaning outside the clinic. Okay. So you'll also be encountering the term out of office. Okay. Out of office can mean two things, no? Your home BP monitoring, which is self-explanatory. This is the blood pressure readings that we take at home, okay, or on your own, by yourself, by your patient, no? And because of that, it's, the more practical approach to BP readings, because it's economical, it's usually taken by the patient, using their own gadgets. The disadvantage is that we don't have, we cannot assure reliability of readings because of the different calibrations of the machines of each patient, though it's the more practical approach. No? So the more objective way of doing an out-of-office measurement is by ordering an ambulatory BP monitor, especially if you are in doubt regarding the accuracy of their home BP monitoring. So this is a machine, no? It's a portable machine worn by patients usually for 24 hours while they go about their daily activities. So it's a small portable recorder. Of course, there's a BP cuff also attached to the arm, on their arms, and there's a recorder that they attach, usually hanged on their shoulder or in their belts. No? And that machine will record the blood pressure of the patient at certain intervals, usually 5 to 10 minutes for 24 hours. It may be bothersome for some patients. Some patients of mine reports that they sometimes are not able to sleep because the cough, of course, takes your BP on a regular interval. Okay, but that's still the most accurate so far in monitoring blood pressure of the patient. It is not mandatory to order an ABPM, only when indicated. Okay? So it's a better method also, no, to predict long-term cardiovascular disease outcomes and office BP. And you have a lot of other information that you can get from an ABP or by doing an ABP. No? So very, very informative. It provides an estimate of your average BP over a 24-hour period, separately during nighttime and daytime. You can see or identify early morning BP surge, because the report will come with a graph of the BP readings during the duration of the monitoring. It estimates your BP variability such that you can time your medication when you think the BP of the patient increases. No? So very good. For example, the BP tends to rise around evening. So you'll want to give the medication in the morning, to cover for the 12-hour period that the BP surges. Higher daytime BP can also be associated with an increased risk of CVD and all-cause death, independent of your office or clinic blood pressure. And since 24-hour BP monitoring can monitor your nighttime BP, then we can use this information as a predictor for coronary heart disease and stroke. Okay. Okay. So another term we need to be familiar with is white coat hypertension. So literally white coat, no? What do you think kaya? Why white coat, no? Kate Biscoccio. Bakit kaya white coat hypertension? Kate Biscoccio? O si ano na lang, Maria Angela San Juan.
Doc, yung sa white coat hypertension po, it often correlates with an elevated BP or an increase in blood pressure due to the effect of, let's say, a patient seeing the doctor. Or
Bakit white coat? Because?
kasi Doc, related po ba siya sa suot ng doktor?
Yes, no. So literally, that's why the term was coined, because of that. Exactly, no, yung white coat of the doctor. So meaning when some of these patients go to the hospital, some are anxious, some are not feeling relaxed, no. So some they anticipate. So there's this psychological effect to their blood pressure. So, but this term has been used. It is not a mere phenomenon like what I described earlier, but it is a condition. It is a real condition wherein you have a patient with an elevated blood pressure in your clinic, but they have normal readings when measured outside the office with either home BP or ambulatory. So there is a relevance to this. So this is not just a mere phenomenon. So there is a clinical significance. It has been typically associated with an increased risk, albeit only slight, but there is an association. Okay. So, of course, since this is only white coat hypertension, it is best managed non-pharmacologically. Okay. Remember, huh? Non-pharmacological. So the best thing is to monitor and recognize the eventual transition to sustained hypertension. Because while we said earlier that in studies it is only associated with an slightly increased risk of CVD, some of these may still develop hypertension. So the key there really is monitoring and to recognize when these patients are going to be hypertensive, to catch them early. But we do not treat them pharmacologically. We don't give them medications. We employ non-pharmacologic methods, which we will learn later. Okay, masked hypertension, it is characterized by office readings suggesting normal BP, but at home or ambulatory BP suggests otherwise. So baliktad, this is the opposite of white coat. So masked hypertension, mask, no? Nakatago. Okay, pag nagpapa-BP sa'yo or sa clinic, normal, but when they go out, no, doing their usual activities at home, their blood pressure pala are elevated. So compared to white coat, this one increases the prevalence of, this has an increased prevalence of target organ damage and risk of cardiovascular disease compared to those with white coat or normotensives. No? So these are the types of patients that you will really have to give pharmacologic therapy in addition to your non-pharmacologic therapy. Okay? Okay. Any questions so far? Okay. Catching up? Digesting? Okay. Wala nang nagsasagot. Okay. Naintindihan? James Beroya. You understand so far? James Beroya. Yes, understand? Naintindihan? Mask and white coat, no? Oh, do you treat white coat? Do you give medications for white coat hypertension? If the blood pressure is 180 in your clinic, do you give them medication? James Beroya.
Hello, hello.
Yes, go ahead.
Rinig po ako, Doc.
Oo, yeah.
Ah, yung tanong niyo po kanina, if I understand po, yung white coat, tama po.
Gagamutin mo ba? May nakita ka, you think it's white coat, pero BP is 180 over 90. Will you give a medicine?
I think po, Doc, if it's anxiety-induced, baka we can help the patient feel at ease na lang po before trying to start medication.
Okay, we will not assume, It's dangerous to assume anxiety, ganyan. But you have to answer straightforwardly, no? That we will not treat because that is the point of this slide, okay? If you think or if patient is diagnosed white coat, meaning you have exhausted all means, no, to call it white coat. What means will you use or employ to really make sure the patient has white coat hypertension? Si Ma'am Jacinth Jimenez. Jacinth Jimenez.
Hi, Doc.
Mm-mm.
Pag wala siya sa... Ay, wait. To make sure po na white coat talaga, kailangan pong
Yeah.
figure out ko ano yung
So what
BP
will
niya.
you
Pag wala
employ
siya sa...
muna? Oh.
Yung, ano po, ABPM po.
Yeah, you will request for either tell the patient to monitor, self-monitor, pwede kasi it's more practical. It doesn't, it's not, patient don't have to spend, no, when they monitor them. Or if they have the capacity naman to pay, then you can request for an ambulatory BP monitor. because it's
Okay.
more accurate than home BP monitor. No? So when you've exhausted everything and the ABP outside office, no? So we'll just say outside office blood pressure has been determined by you to be normal, okay? Even if the blood pressure is elevated clinic, then it is still white coat. You do not give medications, okay?
Yes po.
So this is like a summary table of what we just discussed, no, about sustained masked hypertension and white coat. Okay, so madali naman yan. So office sa masked hypertension, sa clinic, normal ang BP, outside, hypertensive siya. White coat, hypertensive sa clinic, pero outside, walang hypertension. Okay? All right, so these are the corresponding values. No? For a 24-hour BP, there's a normal value for that. For nighttime blood pressure using your ABP, there's a normal value for that as well. Okay, so again, based on 2025 American Heart Guideline, the normal blood pressure is 130/80, okay, and below. So the row with the blue color and the red color is your hypertensive levels, okay? So office blood pressure of 140/90, home BP of 135/85, daytime blood pressure of 135/85, nighttime, okay, nighttime ABPM of 120/70 is already hypertensive, and an average 24-hour ABPM 130/80. Okay, causes of hypertension. Okay, primary hypertension and secondary hypertension are your main causes of hypertension. Okay, so when we say primary hypertension, this is the most common hypertension that we encounter. Okay, in your clinic, probably your relatives, your friends, no? So essentially, this is genetic in character. No? So the etiology is genetic, familial. It represents a spectrum of disorder with different underlying pathophysiology. And there is no obvious anatomic cause. Okay. The other term for primary is essential hypertension. You shall also be encountering the term essential hypertension in some books or publications. But basically, it's the same as primary hypertension. Okay, no obvious cause, and it's familial. Ito na yung tinatawag natin na genetic, no? Genetically predisposed. No? It's an interaction between not only genetics, but environmental factors as well. Okay, and the prevalence increases with age. So the essential hypertension is, or primary hypertension, is the type of hypertension that we see mostly in our patients, no? That the level of blood pressure turns to go up as they age. Okay, so we will not talk about the different genes causing hypertension. I'm sure you don't want to talk about this, no? So it's enough to say that hypertension is a complex disorder, polygenic, meaning multiple genes are involved, that influence the development of hypertension. Okay, in the current tabulation of variants, they have identified more than 25 mutations and 120 single nucleotide polymorphisms causing hypertension. Again, we will not talk about these mutations and the genetic factors of hypertension. It may probably be in another lecture or in your genetics discussion. Okay? All right, so environmental risk factors. The following slides will probably amaze you or surprise you. I hope the following factors are not new to all of us, okay? Because these are very, very common factors we see day to day or experience, or we probably have already in our own body, which can influence the development of elevated blood pressure. So first and foremost, which is becoming malignant already worldwide, overweight and obesity. Okay, we cannot overemphasize this. So epidemiologic studies over the decades have identified a direct, continuous and linear relationship between BMI and linear, okay, almost linear, meaning if the weight increases progressively, your blood pressure increases progressively. If your blood pressure increases rapidly, if your weight increases rapidly, your blood pressure increases rapidly also. So continuous and linear. Continuous meaning it will not stop. Okay, as we grow bigger, our blood pressure also increases higher. Okay, and linear. No? So amongst the parameter for obesity, it has been said that the waist to hip ratio has a stronger correlation for the development of hypertension, and CT, computed tomographic measures of central fat distribution. Okay, another factor which I think we often disregard, okay, is sodium intake. No? So it accounts for age-related increase in blood pressure. And the salt sensitivity is a quantitative trait in which an increase in sodium load disproportionately increases blood pressure. So grabe ang effect na sa blood pressure. No? Disproportionate ang increase na sa blood pressure. Okay, of course, the salt sensitivity in studies are different among different races, especially in the Blacks and the older adults. And those with higher comorbidities, like CKD or chronic kidney disease, diabetes, and metabolic syndrome. Okay. So another one is potassium, no? Potassium. So if you have sodium, you have potassium. Okay. So if you have an increase in sodium intake, you increase blood pressure. If you have a decreased potassium intake, you increase blood pressure. Okay. See, Paul Borromeo is still here. Paul Borromeo. Paul, are you still with us? Wala pa siya. Christine Reyes. Christine Reyes, want to join us? Christine Reyes. Please follow our house rules, okay? So turn on your audio, okay? So I'll know that you understand the lecture, okay? Christine Reyes. Cherish Blando.
Yes, Doc. Good afternoon.
Good afternoon. So where do you get potassium? Which food groups have rich in potassium? Cherish. Potassium lang.
Mainly po in fruits po, Doc. Like specifically like bananas po.
Fruits, okay? So fruits, so meaning you just increase your intake of fruits, you counter hypertension, okay? So again, as I've said earlier, we often disregard these things. We have them, probably, you encounter them every day, but you probably just disregard, no? Like the power of the fruits, no? Or food groups rich in potassium. So because a higher level of potassium seems to blunt the effect of sodium on our blood pressure. Okay? With a lower level of sodium potassium ratio, it's associated with a lower level. So by just increasing your fruit intake in the diet, you counter blood pressure, high blood pressure. Physical fitness, we already know that, okay? A modest level of physical activity has always been associated with the increase or decrease or in the risk of hypertension. Environmental risk factors, no? Alcohol, it has a direct relationship between alcohol consumption and BP. Of course, you may probably ask, or your patient may be asking, pwede ba daw kahit konti lang? Okay, how much is too much? How much or can we consume so that we will not develop hypertension? The answer is we do not encourage drinking alcohol because in studies, it has been shown to be correlated with hypertension. So the best way to answer your patient is we will not encourage the use or intake of alcohol in our patients, especially if they have maintenance medications already. Okay, heavy metals, these are the less common risk factors. No? We don't work in the mine anyway or in the mines, but just note that these metals or heavy metals can cause hypertension. Air pollution, okay, we have that everywhere, no? Especially with particulate matter with a diameter of 2.5 microns or PM2.5. Okay, we now go to secondary hypertension. Okay, less common than the essential or primary hypertension, but very, very hard to identify and treat. Okay, so when we say secondary, there is a secondary cause. There is a specific remedial cause or underlying cause that can be identified. Pag sinabi secondary. So it should be considered in the evaluation of all patients with new onset hypertension, okay, or in selected patients with prevalent or existing hypertension who have the following, no? Who have the following. So these are your, shall we say, red flags, okay, to say, this patient probably has secondary hypertension, okay? So again, newly diagnosed hypertensive or in previously hypertensive patients, no? You may suspect secondary cause if number one, they have treatment-resistant hypertension. These patients are not responding, okay? Even if you were already given the most potent, a lot of antihypertensive medication, they are not controlled, then you may suspect probably this is secondary hypertension. Number two, abrupt worsening, okay? So patients who have been previously controlled, all of a sudden, their hypertension goes up dramatically, okay? Probably there is an underlying cause. Okay? Number three, disproportionate target organ damage for the level of blood pressure. For example, BP has, not really too high, 150, 140 over 90, but on evaluation, the kidneys have been diseased already. They have multiple strokes already. Then you can suspect a secondary cause of the blood pressure. Okay, and lastly, or last but not the least, laboratory or diagnostic findings. No? So you need laboratory requests or tests for this, no? Such as unprovoked hypokalemia, proteinuria, or left ventricular hypertrophy. Okay, so remember these red flags when you go see your patients with hypertension. At any time that you see these four factors or identify these, always suspect probably there is a secondary cause. Okay, it's very important to identify the secondary cause because that can spell the difference between worsening and eventually them suffering from the effects of the worsening of the hypertension versus treating them, no, or abating or stopping the progression of their condition. Okay, okay. So listed here, this is also uh, found in your textbook, no? Your common and uncommon causes. We will just touch some of these, but the common causes, we will identify them one by one. No? The renal parenchymal, renovascular, primary aldosteronism, obstructive sleep apnea, and the drug or alcohol use. Okay, obstructive sleep apnea. It is probably the most common cause. Okay, why probably? Because, when you diagnose obstructive sleep apnea, you really have to spend a lot of money for you to be able to be diagnosed, no? Because OSA, clinical diagnosis of OSA, will include a sleep study, okay, or polysomnograph, which is expensive, okay? So probably a lot of patients remain undiagnosed with or for obstructive sleep apnea, but I think this is a very common phenomenon, especially uh, in a population which is, getting fat and bigger. So OSA also becomes more prevalent, such that hypertension or secondary hypertension also becomes more prevalent. So in OSA, there is, patients snore, okay? They snore because of the collapse of the upper airways during sleep. Okay, it's not really the snoring that is a problem, but actually the intermittent episodes of apnea or hypopnea and sleep disruption. Okay, when they snore, of course, the intake of air into the lungs is cut off. Okay, resulting, to poor quality of sleep and daytime sleepiness. Okay, so since they have not been able to sleep well, they feel so tired the following day. Their cardiovascular status suffers also because of hypoxemia or lack of oxygen. Their blood pressure uh, eventually tends to increase. Okay? Okay. Renal parenchymal disease, also one of the most common, okay, especially in the Philippines, where dialysis centers have been mushrooming all over. Okay? So virtually all disorders of the kidney may cause hypertension, whether interstitial or glomerular. Okay? And the main mechanism responsible is your RAS. Okay? You're very, very familiar RAS. So it is more common in glomerular diseases, no, like your glomerulonephritis, than your interstitial renal diseases, the kidney disease resulting from UTI or infection. So more common in severe and glomerular. So suspect a patient with secondary hypertension, with those with recurrent UTI, those with hematuria or blood in your urine, nocturia, those with polycystic kidney disease, which is familial, and elevated serum creatinine and abnormal urinalysis. Okay, next is renovascular hypertension. So renovascular, meaning artery of the kidney. Okay, so due to occlusive lesion of the renal artery or renal artery stenosis, okay, it is caused by atherosclerosis, okay, commonly unilateral And the principal obstruction tends to present as a discrete lesion found close to the origin of the renal artery. So you have to identify these two groups of patients at risk. The older patients and the younger population with fibromuscular dysplasia. Okay, how to identify this? Okay, important ito ha. So if you have a renal artery stenosis obstructing the renal artery more proximally, and there is only unilateral involvement, then you suspect renal artery stenosis in the elderly population. Okay. If your patient is young, generally young, female, the lesion is bilateral, diffuse, and the renal artery stenosis is located in the more distal part, then you suspect fibromuscular dysplasia. Okay? Naintindihan? So diagnostic tests would include your ultrasound or CT and MRI. Okay? So you need an imaging study to identify renal artery stenosis. Also, renograms and measurement of your plasma renin activity. But of course, the more definitive test, no, and the gold standard is your renal angiography, wherein you can really see the area of stenosis during the procedure. So when do you suspect that the patient has renovascular stenosis or renal artery stenosis? So if the patient has refractory hypertension, and then there's a sudden loss of hypertension control, no? And the onset of severe, biglang lumala, tumaas yung blood pressure abruptly, and there is unexplained deterioration in renal function. And this deterioration is associated with ACE inhibitor intake. No? So actually, we do not know if our patients have secondary hypertension. And we definitely will not know if the patient has renal artery stenosis. So sometimes, no, hindi man magandang pakinggan. Sometimes, the renal artery stenosis is provoked, no, by giving ACE inhibitors. Because ACE inhibitor, we admit it's a very common medicine, and we don't know if they have renal artery stenosis. But when these patients are given ACE inhibitors, suddenly their renal function deteriorates. Suddenly their blood pressure shoots up, okay, unexplained, okay. Then you should suspect, as a physician, always suspect this patient to be having renal artery stenosis. You should now withdraw your ACE inhibitor, okay. So ACE inhibitors are contraindicated for renal artery stenosis. Also, if you do a full physical exam, you may, it's not all the time that you can detect this, but you may do auscultation of your flanks and abdomen to check for RUI, okay? But again, this is not very specific for renal artery stenosis because those abdominal RUI may also denote aortic aneurysms, okay? But it's recommended to still do your abdominal auscultation, especially if the sound lateralizes or extend throughout systole into diastole. Okay. Okay. Primary aldosteronism. Okay. Excess aldosterone. Okay, what is aldosterone for again? Kate Ignacio, are you still here with us? What is the purpose again, or the action of aldosterone? What does it do? Kate Ignacio. Nicole Verdillo, go ahead.
Hello po, Doc. Aldosterone po, its primary purpose po is to maintain sodium homeostasis po, which directly impacts water retention and overall fluid volume po.
Okay, so aldosterone is a hormone that retains sodium. Okay, so if you have a lot of sodium, you have a lot of volume, then you have hypertension. So in patients with primary aldosteronism, there is excess in the production of aldosterone. So why are these patients have an excess? Number one, you can have adrenal hyperplasia. Okay? Malaki yung adrenal gland, bilateral usually. Or there is a tumor, okay, which is usually unilateral, aldosterone producing adenoma. So these are the two most common causes why patients have primary aldosteronism. Again, very hard to diagnose, especially if you're just seeing them for their hypertension, unless you order for blood tests like the potassium. Okay, so the aldosterone production is inappropriately high for the sodium status and results in sodium retention, plasma renin suppression, and increased potassium excretion, which can cause hypokalemia. Okay, so caused by bilateral renal hyperplasia, or if it is an adenoma, it is usually unilateral. Okay, okay, so most are asymptomatic, no? Asymptomatic. Sometimes they have polyuria, they pee a lot, polydipsia, they drink a lot, and weakness or paresthesia due to hypokalemia. Okay. Physical exam, very hard also to identify. Some have arrhythmias. If you can pick up their irregular beat, and this is usually again due to hypokalemia or low potassium. Diagnostic test, you will have to employ imaging study like a CT scan, measurement of your aldosterone ratio in conjunction with your plasma aldosterone levels, saline suppression and cup-to-pill challenge test, and adrenal vein aldosterone sampling, which is the gold standard. So these tests, no, are not basic tests for hypertension. No? In fact, all of the tests for secondary hypertension are add-on. When you suspect a patient has secondary hypertension, that's the only time you request for these tests, no? For each condition. Okay. Okay. Drug or alcohol induced. So there are a lot of prescription meds that can cause hypertension. Especially your decongestants, okay? Yung mga mahilig sa decongestants dyan, because they contain phenylephrine. What is phenylephrine? What is the action? We learned that earlier. Not phenylephrine, but something else. Crystalloplaon. From the term itself, phenylephrine. Sounds like ano yan? Crystalloplaon. So again, very common medications that we sometimes take and just disregard or are not aware of its effects. Decongestants, Neozep, okay. Yes, Paulo Fabros. Similar to your what? Epinephrine, okay? So what is the effect of those, no? Vasoconstriction, okay? So this phenylephrine, albeit in small doses, but if you repeatedly take them, can eventually cause vasoconstriction and increase your blood pressure. Herbal, not all, but sometimes those with, mga licorice containing agents. Okay? Of course, your prohibited drugs, okay? Your cocaine, ephedrine. Okay? So sometimes you suspect these in patients who have fine tremors, tachycardia, and so on. Okay. All right, hypertensive disorders of pregnancy. Again, very important, no? You'll have a separate lecture of this probably when you go to your obstetrics and gynecology rotation, but we'll touch them in a few. Okay, so hypertensive disorders, these are hypertension which are complicated by preeclampsia, in which it is accompanied by proteinuria, a protein in your urine or other evidence of target organ damage. It is usually associated with the HELP syndrome. So this is a more severe form of preeclampsia. No? In HELP syndrome, it's an acronym for hemolysis, elevated liver enzymes, and low platelets. So these patients usually bleed, no, because of low platelets. So HELP syndrome. So these preeclampsia patients may, not all, but some may progress to eclampsia. When we say eclampsia, you have all of these factors from preeclampsia, elevated blood pressure, HELP, but patients now have seizures as the cardinal feature. So when they develop seizures, that's what we call eclampsia already. Okay, and there's a higher rate of fetal complication and CVD complications for the mother later. Okay, so you have four types, no? Four terms to remember, okay? So you have chronic hypertension. This is a classification wherein the blood pressure is already elevated prior to pregnancy. Okay, so hypertensive na sila to begin with before they got pregnant. Gestational, we say gestational, when the hypertension is recognized after 20 weeks of gestation. Okay, and then preeclampsia potentially culminating in eclampsia, and there are also patients who have chronic hypertension, so hypertensive na before they got pregnant, but during pregnancy there's superimposition of preeclampsia. All right, first line treatment, beta blockers, CCB, a calcium channel like your nifedipine or your centrally acting alpha adrenergic agonist. So this is one of those conditions where we still use alpha agonists, no? Alpha adrenergic agonists or methyl dopa, because these three drugs are the more safer agents to use in hypertension. You will find a long list of medications which are contraindicated for hypertension. In fact, beta blockers 10, 20 years ago is not indicated, no? It's contraindicated for pregnancy. But now they have shown some safe use for it already in pregnancy, especially labetalol. Okay, hydralazine may be used as second line. And another important medication that is really, really contraindicated are your RAAS inhibitors, no? Your ACE and your ARB, because of the potential for teratogenicity. Okay, so ACE and ARBs are contraindicated for pregnancy. So far, Jarlene Salanga, are you still here with us? Jarlene. Natulog na. Jarlene Salanga.
Yes po, Doc.
Okay, so can you now name two conditions where we cannot give, okay, or where ACE and ARBs are contraindicated? One is right in front of you. Nandiyan na, sa harap mo. May 1 point ka na.
Pregnancy po pagkatapos bilateral. Renal artery stenosis po, Doc.
Okay. Wag na yung bilateral. Renal artery stenosis lang yan. Okay? Okay, so renal artery stenosis. And pregnancy, okay, we cannot give ACE inhibitors and ARBs. Okay. Renal artery stenosis. Okay. Next slide. Okay, pheochromocytoma. Okay, so pheotoma, when we say toma, tumor, right? So pheochroma, it's a benign tumor. Because of this tumor, which is usually paraganglioma, it's a catecholamine secreting tumor. No? So catecholamines, so it's located in the adrenal medulla or paraganglion tissue, which produces increased blood pressure. So history usually can be picked up by patient having a lot of palpitation, sweating, no? Because catecholamines, so what are your catecholamines? You know, epinephrine. So they have high blood pressure, high cardiac rate, they sweat a lot, they have headaches, no? BP spells, no? And then there is a tumor usually. Okay? And the diagnostic tests for that are, of course, imaging studies and blood tests. Cushing syndrome, you have excess cortisol production due to ACTH production, excess ACTH in your pituitary, no, or ectopic tumor, or ACTH independent adrenal production of cortisol. So these patients present with rapid weight gain. The weight is usually centrally distributed. They have proximal muscle weakness and depression. So these are the types we see that have central obesity and moon fascie. Okay, moon fascie. Also similar to those taking chronic steroids, oral steroids. No, you'll see them having moon fascie and central obesity. So they have Cushing's syndrome. Okay, coarctation. This is a congenital abnormality. No, it is the most common congenital cause of hypertension in the younger population, less than 30 years. So if you have a patient very, very young and you have a discrepancy in blood pressure between the right and the left, then you suspect coarctation of the aorta. Okay, you can also appreciate a systolic murmur in the left interscapular area and a blood pressure higher in the upper than the lower extremities. Okay? We've learned from PB2 class, no, that we can also, that we should measure bilaterally a patient's blood pressure. Okay, so if you have discrepancy in the blood pressure of the upper arm between the right and the left, then you take your blood pressure of the lower extremities. You can catch the diagnosis if you have a higher blood pressure in your upper than in your lower. And then absent femoral pulses in the more severe ones. Okay, okay, this table can be found in Harrison's. This is just a summary of what we have already discussed. No, this is a very good table to study or review. Okay, so just go through that when you go to your when you read the Harrison's. Okay, okay, treatment. So we have non-pharmacologic, pharmacologic, and catheter-based therapy. Okay? So this algorithm generally shows us the approach to hypertension. Okay, so briefly, if you have a systolic blood pressure less than 120 over 80, in our classification, normal, no? Normal blood pressure, then we just encourage non-pharmacologic or healthy eating habits or lifestyle. Then we assess after a year. Okay. Elevated blood pressure, again, non-pharmacologic therapy, but you tend to make them follow up much earlier, no? 3 to 6 months. In the hypertensive range, so those with stage 1, stage 2, depends on the overall risk, your ASCVD, atherosclerotic cardiovascular disease, risk score, then it depends on what the risk score. If it's not high risk, then you also employ non-pharmacologic. We only recommend pharmacologic if you have a patient with high risk in your ASCVD scoring, you have a prior cardiovascular disease, you have a high risk of CVD using your risk calculator, and you have a phenotype, familial, or stage 1 hypertension, age more than 65 with diabetes insipidus. Then you employ or institute pharmacologic therapy. Okay? What is this ASCVD calculator? You can find this in the internet. It looks like this. There's no app yet for this, but you can search the web and you just input the following values, and then it will give you the risk of your patient, the 10-year ASCVD risk. Okay? So madali lang yan. Okay? So I encourage you to use this because this is validated by decades of research and studies. All right. Okay, non-pharmacologic, diet, weight reduction, and sodium intake. No? So for the diet, we have to encourage the DASH diet, dietary approaches to stop hypertension. So these are readily available on the internet. If you want, you can also advise your patient to go to your dietitian so they can prepare DASH meals for them. Okay, so the expected improvement in BP reduction can be around 5 millimeters mercury, no? With good adherence to the diet. Body weight, again, we cannot overemphasize it. No, we have to target the ideal weight of your patient. So using your BMI, so a reduction of 1 millimeter mercury for every kilo of body weight is already significant. So madali lang tandaan, 1 kilo reduction for every 1 millimeter mercury. 1 kilogram decrease in body weight produces 1 millimeter mercury reduction in your blood pressure. Okay. Sodium intake can reduce your blood pressure, systolic blood pressure by around 5 millimeters mercury if patients decrease their intake by 25%. Okay, so the more common way to say low salt intake, if you want to be very technical about it, is around 1,500 to 2,300 milligrams of sodium. Okay, or average, you just say 2 grams of salt a day. How much is 2 grams? A pinch of salt. Okay, pinch of salt in a day. Okay, potassium intake. Okay, so you find it in your fruits, vegetables, or supplements. Okay, physical activity, anything, no, aerobic, dynamic, isometric exercises. So again, a reduction of 5 millimeters mercury in your blood pressure with constant physical activity. Alcohol consumption, also a reduction in 5 millimeters mercury without or after stopping your alcohol consumption. Okay, so now we go to pharmacologic intervention. Okay, so we will just discuss the more common drugs used and currently available in the market. This is also found in your Harrison's. Okay, so please take time to review, especially the actions. You don't have to memorize the dose, huh? Okay, don't have to memorize it. Good if you can, but you don't have to. Okay? So the diuretics are your thiazide and thiazide like. We do not use the other diuretics, huh? What other diuretics pa can can you give us, no? That is not used for hypertension. Caitlin Sanchez. Are you familiar with diuretics? For anyone, what is that very familiar diuretic, but we do not use for hypertension?
Doc,
Yes, go ahead.
mannitol po, Doc.
Yeah, mannitol, ano pa, furosemide, no? So we don't use these diuretics. When we say diuretics for hypertension, we only refer to the thiazide and thiazide-like diuretics, which exert their action on the tubules and block the sodium reabsorption in the distal convoluted tubules. No? So though, they are safe for hypertension and using hypertension, be wary of the common side effects of diuretics. So they can induce electrolyte imbalances, like hyponatremia. Okay? Kasi it blocks sodium reabsorption. So patients may eventually develop low sodium, low potassium, high calcium, high uric acid, even hyperglycemia and increased in cholesterol levels. Okay. ACE inhibitors, there are a lot of ACE inhibitors in the market. Listed here are the more common ones approved in the US market, but there is also captopril, perindopril, which is not listed down here. So these are just the more common ones used in the United States because this is a book published majority by Americans. Enalapril, lisinopril, ramipril, trandopril. But here locally, we also have perindopril, still have captopril. Okay? And the guideline for using ACE inhibitors, since it is somewhat similar or same family as your ARBs or ARBs, you do not use them in combination. Okay? Do not use ACE in combination with ARBs because they basically have the same action. So what? No? So baka may magtanong, di mas maganda, no? So they can potentiate the antihypertensive effect. Yes, probably, but they can also potentiate the adverse effects. Okay? So you risk your patient having hyperkalemia and most probably baka ma-affect pa ang kanilang kidneys. So you do not combine. Okay, you understand? Okay, ARBs, very, very common in the Philippines. In fact, it's probably, I would say, the most common antihypertensive. Okay, represented by your losartan, valsartan, azilsartan is not available here, candesartan, olmesartan, telmisartan is not listed there, telmisartan, irbesartan. Okay, so those ending in sartan. ACE inhibitors, they end in pril, no? Pril. ARBs, they end in sartans. Okay. So again, you do not use them in combination with ACE inhibitors. CCBs, okay, take note, I will highlight this. You have two types of calcium channel blockers. Okay. Calcium channel blockers. You have your dihydropyridines and your non-dihydropyridines. Okay. So, anong difference nila? So, there's a big difference, okay, when you use dihydro versus non-dihydro. Para you can remember what are the dihydropyridines? Just remember the dihydropyridines and in dipin, dipin, amlodipine, felodipine, nifedipine. Okay? Naintindihan? So, dihydropyridines. Kumbaga, the mnemonic is dipin, dihydro. Naintindihan ba yun? Tingnan ko ako nito. Moel Pelayo, are you still with us? Mole pala. Mole. Tilayo. Tilayo. Yes. Oh, what are your dihydropyridines? Give me an example. D, dihydro. Angelo Castillo.
Doc, one type of dihydropyridines po is amlodipine po, Doc.
Amlodipine, ano? Dipine, dihydro. Okay? So, tandaan nyo yun, ha? Okay. Dihydrodipine, D. Non-dihydro, they sound differently. Diltiazem, verapamil. So, ibang-iba siya, no? So, the only way to differentiate is to the letter D. Dihydro is D, dipine. Okay. So, anong difference? What are dihydro and non-dihydro? So, dihydropyridines of the CCB class, they give us tachycardia. Okay? Non-dihydropyridines, the effect is bradycardia. Okay? Naintindihan? Because they act on somewhat a different pathway. Okay? So dihydro being primarily inhibiting the entry of the calcium cells. That's why it gives you tachycardia. Okay, so opposite yung action, ha? But they produce the same endpoint, which is to reduce blood pressure. Okay, so meaning if you have a patient, let's call nga Matthew Karating. Matthew Karating. Matthew. Lian Tizon. Are you still with us? Lian Tizon. Lian. Wala din. So, Albert, our secretary, are you taking notes? No, Albert, just take note of those who are not present, huh? Si Alessandra Rojas. Alessandra Rojas. Alessandra Rojas. Ayaw din, sumugot. Moriel Valenzuela. Moriel Valenzuela, please open your microphone, please. Alessandra Rojas, please open your microphone, please. Okay, we shall proceed. Okay, other hypertensive disorders or terms that you need to remember are this one. First is resistant hypertension. It is defined as blood pressure elevation, which is failure to control systolic and diastolic blood pressure to less than 130/80 with 3 antihypertensive medications, preferably including a diuretic or taking 4 or more antihypertensive medications to achieve a systolic blood pressure and diastolic blood pressure less than 130/80. Okay, resistant hypertension. Renal denervation should be considered in patients with true resistant hypertension if still with office blood pressure of more than 160. So renal denervation is a recently approved intervention using ultrasound and radiofrequency ablation as adjunctive treatment for resistant hypertension. So this is now what we call catheter-based therapy for hypertension. So you don't only have non-pharmacologic, you have pharmacologic, and you also have catheter-based intervention. This is already available in our country, so we can employ or advise patients if they meet a very, very strict criteria for this. No? So you should know about this because this is already available and it is already one of those strategies used in hypertension. I'll show you a brief video of this. I hope the sound is okay, no? Okay. On how this is used. Very amazing technology, very simple, of course expensive when I talk about the price. Only a few institutions can do this. Of course, UERN does not have the capability to do this because we don't have a cardiac catheterization laboratory. But you can ask your patient to go to Philippine Heart Center or St. Luke's, no, for these devices or procedures.
Introducing
Can
the
you hear
Simplicity Spiral
the
Catheter
audio?
and Simplicity G3
Yes,
Generator from Medtronic, the pioneer of renal denervation. Patients with uncontrolled blood pressure may have an overactive sympathetic nervous system. Renal
Sorry.
denervation. Introducing the Simplicity Spiral Catheter and Simplicity G3 Generator from Medtronic, the pioneer of renal denervation. Patients with uncontrolled blood pressure may have an overactive sympathetic nervous system.
So our renal system, the red thing in the center is your aorta. The two vessels left and right are your left and right renal arteries. Now, embedded or on top of your renal arteries are your sympathetic and ganglionic nerves, no, that also contribute and control your hypertension. This is the target of this catheter. The purpose is to ablate or to stop the function of hyperactivity of these sympathetic nerves. Okay, a very, very novel concept, no? But it has now been a reality, and patients now have benefited from this.
Denervation aims to suppress this elevated sympathetic drive. The Simplicity Renal Denervation System ablates the renal artery nerves that carry the efferent and afferent sympathetic signals, which has been proven to reduce blood pressure. The Simplicity Spiral Catheter and Simplicity G3 Generator offer an extremely efficient and simple method of performing renal denervation. The Simplicity Spiral Catheter offers exceptional deliverability and ease of use, short procedure and ablation times, and consistency of deployment in a wide range of anatomies. The Simplicity Spiral Catheter is a 6 French compatible catheter that is delivered using a rapid exchange system.
We just puncture your femoral artery to pass this blue catheter into your aorta, okay? Because when you the femoral artery, when you go up, it's your iliac and then your aorta to reach the renal artery, okay? These catheters are specifically designed or shaped to enter the ostium or the cavity of your renal arteries, just like in this video. Okay?
The standard .014 guide wire. When the guide wire is retracted, the Simplicity spiral catheter naturally conforms to the patient's renal artery without occluding blood flow. It is capable of treating a wide range of arteries as small as 3 millimeters in diameter and as large as 8 millimeters. The Simplicity spiral catheter uses the same helical ablation pattern established by the proven Simplicity Flex catheter. The energy delivery from the Simplicity spiral catheter is controlled by the Simplicity G3 generator. The generator allows the physician to monitor the impedance and temperature measurements of each electrode. The RF energy is delivered simultaneously through all 4 electrodes and utilizes Simplicity algorithms that safely and effectively lower blood pressure.
So the radio frequency waves delivered from the machine outside to the catheter ablates the sympathetic nerves. Okay.
After a single 60-second ablation, the Simplicity spiral catheter is repositioned into the contralateral renal artery and the ablation procedure is repeated.
Okay, so I think we're down to our last few slides. Very important terms again, your hypertensive crisis. You can have hypertensive emergency and hypertensive urgency. Okay, so they sound similar, but they are really very, very different. So be familiar with the term. Okay? When you say hypertensive emergency, you have a blood pressure of more than 180 over 120 with evidence of target organ damage. So what are your target organ damage? It can be stroke, it can be pulmonary edema, it can be left ventricular hypertrophy. Okay, so this target organ damage is associated with that rapid or elevated blood pressure of more than 180. So immediate reduction of BP is not necessarily to bring it down to normal, okay? But you have to bring it to lower level gradually to stop progression of the target organ damage. So your goal for hypertensive emergency is not to bring down the blood pressure to normal level, okay? Ang goal natin is to stop worsening of the target organ damage. So the management is intravenous administration or IV antihypertensive medications, because we want to stop the progression. So oral agents are discouraged because it will take time for these oral medications to take effect. As compared to your hypertensive urgency, which are more common, it is also associated with severe BP elevation, but without acute or target organ damage. Okay, that's the main difference between the two. In terms of management, they also differ. So the patients with hypertensive urgency, you may employ adjustment of your medications, or if they have not been on any antihypertensive med, institution of antihypertensive med, and intensification, okay, if inadequate, kung kulang. So those 3 important points, institution, reinstitution, or intensification of oral antihypertensive agent in an outpatient setting. So these patients don't have to be admitted in hypertensive urgency. Sometimes they on their own, they go to the emergency room because they have a BP of like this, 180 or what have that. But you should not admit these patients if they don't have impending organ damage or worsening of the target organ damage. Because you just have to employ institution, reinstitution, intensification of your medications. Okay? Any questions? Any questions? Nag-extend tayo ng 11 minutes because we also started late because we waited for most of you. Okay, any questions? None? Let me see in the chat box. None also. Okay. So if there are no more questions, thank you for listening. I hope you learned a lot from the lecture. Huh? Okay. I want you to understand hypertension in a way that you can also teach this to your classmates and to your patients and to your future students should you become teachers yourself. Okay? Okay. Thank you and good day.
Thank you, Doc.
Thank you po, Doc. Thank you po.
Thank you po, Doc.
Thank you.
Thank you po, Doc.